When I was preparing this talk, I was thinking, I don't really get restenosis, so I'm not really sure what I'm supposed to talk about. In fact, nobody in this room gets restenosis, right? Because we're interventional cardiologists. We all have great results. Well, it turns out that that's not completely true. And in fact, from the national database, about 10% of PCIs in the US are for in-stent restenosis, and more than half of them present with ACS. This was really contrary to my understanding. I thought that patients with ISR present with stable coronary syndromes because the neointimal hyperplasia is progressive, they slowly tighten, and as they exercise, they present with exercise-induced angina. So what's the big deal if you get a stent failure then? It's not a big deal. They get a restenosis, they come back, they get another stent or drug-eluting balloon. But in actual fact, you see clearly that many of them present with ACS, and in fact, their MACE is worse for ISR patients. And what we also know is that the minimal stent area is an independent predictor for ISR. The bigger the highway, the less likely you are to have a traffic jam. We published this data from CRF, which shows that the reality is that target lesion failure and target vessel failure accrue over time, and that there is an ongoing, consistent, and persistent 2% accrual rate of stents even in 2022, even with third-generation stents. So there's something about putting metal into the coronary artery that leads to problems over time. It's important for us to know that this is a time-dependent phenomena, and it's quite sobering to think about the fact that basically 1 in 6 patients that you treat within 5 years fails. That's not great. So it's sobering and important for us to understand. Who gets in-stent restenosis? And if we stratify this over time, you can see that total stent length, which actually is a misnomer, it should be total lesion length, but we don't measure the lesion, we measure the stent. That's important because there's a discrepancy between lesion length and stent length when it comes to intravascular imaging. Intravascular imaging increases your stent length, but reduces your event rate. So really, this is about lipid and plaque. When we go from 30 days to a year, diabetic patients, hypertensive patients, moderate to severe calcium, and you're going to see this recurrent theme of patients with reference vessel diameters that are small, and the diameter stenosis pre also impact. And in the long term, again, it's the diabetics, it's the patients with aggressive disease like prior PCI and CABG, and there it is again, the reference vessel diameter. So what's the big deal, right? So, what happens? Well, the big deal is it's pretty darn costly to have an ISR, right? So a de novo lesion is a controlled event, costs not so much, but if you have an ISR, they usually present, as I showed you, with an ACS. They require a lot of MD services and as a result have a very high attributable cost. Not only that, but what you'll notice is that when you look at PCI in the ADAPT-DS registry, the events that happen in patients with restenosis is not just target vessel failure. The large proportion of them are spontaneous myocardial infarction and stent thrombosis, both of which are really bad. I think I'd rather have a target lesion revascularization than have a spontaneous MI or a stent thrombosis, both of which have profound impact on clinical outcomes. You've seen this slide before, and I've presented it in a different way, but today what I'd like to highlight to you is look at the highest hazard ratio. The highest hazard ratio of all of the events is ISR. It's even higher than it being on dialysis, which is a pretty darn high event rate. So what am I supposed to do with this information? Well, we could image. We know if we image, we reduce the MACE rate, we reduce the stent thrombosis rate, we reduce the myocardial infarction rate. I just showed you from the same study the data that shows if you get an ISR, these events are reduced. So I think that's strong evidence to suggest that using imaging is helpful. We've seen this data that we know that not only at 1 year do you get a benefit, but because there's an accrual of reduction in target vessel failure over time, that benefit from imaging-guided PCI continues over time. And it does so in different cohorts. It does so in patients with long lesions, but also in all comers. Now, this is really sobering. This is 6,000 patients undergoing PCI for complex lesions in a prospective single center registry, and I was absolutely astonished to see that ISR lesions were probably the lowest use of IVUS guidance. This just makes no sense to me. Why, when you have a failed device and you can take a picture from the inside to figure out why that happened, you wouldn't do it? It really, really is flying blind. So let me convince you, why should we image for ISR? One, we identify the mechanism. Critically, we identify the number of layers. And probably the most important thing that you're going to get out of this is that when you put the second layer of stent in and you get an ISR, it is the kiss of death. It is extremely difficult to expand that stent. And then, of course, we can tailor treatment. Now, for years and years and years, we've been using the Moran classification of ISR. And I'm proud to say that my friend and colleague Evan Schlafmitz published this update of restenosis with the Schlafmitz classification, which is really much more contemporary with how we can act on what we find. It's not just simply diffuse or focal, it's mechanical or biological or mixed or CTO. And then you can see that there is a separate column for 2 layers of stent because 2 layers of stent is in fact a separate beast. We need to know that the time from the index PCI heavily impacts what the mechanism of our stent failure is going to be. Very early on, it's likely to be under expansion. You'll also see that over time, we tend to develop neointima. And then, as the neointima matures in a patient with all the risk factors for atherosclerosis, they develop neoatherosclerosis. And in the end, we can even develop this new phenomena of neocalcinosis, where you have calcium developing as the neoatherosclerosis. What about the treatment algorithm for ISR? So we've talked about why this happens, why it impacts patients, what the problem is. And this is how we can use the information that we get in terms of defining by intravascular imaging what type of ISR we actually have, how we can guide treatment. And you'll notice over in the corner, type 5, where there's greater than 2 layers of ISR, there's not another option for a stent. This is bypass, brachytherapy, and DCB. The role of DCB is dramatically increasing, and I think that's very, very relevant. Now, since this is an imaging and physiology session, I think we need to look at the nuances of IVUS versus OCT. And I know Gary's in the audience. Many of us for years have said, honestly, it doesn't really matter if you do OCT or IVUS because we know that they're probably going to end up giving you the same clinical outcome. That might be different in ISR. Let's look at some co-registered images together. So here's a patient with neoatherosclerosis, but you can't really appreciate the neoatherosclerosis easily on the IVUS. However, on the IVUS, we're able to see the media. So we can determine how big this artery actually is, but we really can't do that because of signal attenuation on OCT. This is the problem with calcification on an IVUS. Number one, it obscures the struts. Number two, it obscures the distance from the lumen to the struts. And you can see in this co-registered image, you can actually see the calcium is actually very, very thin on the OCT. But on the IVUS, you can't tell how deep it is. Here's another example of the same phenomena, where very thin calcium, neocalcinosis around the struts, is really not bothering the patient at all or not really biologically relevant, but gives the appearance of dense calcification on IVUS. We're also easily able to identify tissue using OCT that's much more difficult because of the resolution on intravascular ultrasound. And of course, the detection of stents, and as a result, the detection of the number of layers is easier with the high resolution. We're also easily able to measure the neointima on OCT compared to IVUS. Finally, you can see that when we have deep calcium on the OCT, it appears to be superficial or luminal calcium on the IVUS. And that has relevance with regards to how we're going to treat. I'm going to spend my last few minutes talking about what I think is the next paradigm in interventional cardiology, particularly the coronary, and that is the use of the drug-eluting balloon. So right now, the treatment options for ISR, if we look at the most contemporary data, about 20% of patients are getting POBA and 73% are getting drug-eluting stents. This is from the NCDR. Enter the DCB, which gives us similar restenosis rates to drug-eluting stents and avoids the concerns over multiple stent layers. And in fact, it may help us facilitate future treatment. I'm not going to summarize 17 different trials. I'm actually just going to show you one important meta-analysis. In fact, I vow to you, you'll never see more than one meta-analysis on any of my presentations because you only need one. That's the whole point. And what you'll see is, in fact, that when you look at drug-eluting stents compared to drug-eluting balloons, the hazard ratios are very, very similar. And in fact, the clinical impact of the drug-eluting balloon versus the DES favors the paclitaxel-coated balloon. Yes, the absolute binary restenosis rate is higher in patients who have drug-coated balloons, but you get to kick the can down the road and prevent that second layer of stent ISR, which, as I said, has very limited options. Are we ready to use drug-eluting balloons in de novo disease? No, but the DEBs have impacted our practice and are now level 1A for for treatment of ISR. Interestingly, for IVUS and OCT, we get a 2A. I think there's probably no better place to use intravascular imaging that has more clinical impact. Why is this important? And the reason is that the lesion morphology is actually critically important. What we can see is that stent underexpansion or no stent underexpansion differ markedly with the expansion of the new stent. Okay, so when you put a stent inside a stent, it's very hard to expand it. It's a metal cage inside a metal cage with a thick layer of fibrous cellular tissue, which actually has high relevance. And that has relevance along with calcification. So it's not only calcification, it's both the fibrous layer and the calcium. So I think what I'm going to do in the sake of time is stop here. I was going to show a case, but to be honest, I think the cases that we've seen have also been highly impactful, and say thank you for your attention.